Well, I'm delighted to be here. I have the privilege of taking care of some of U.S. patients, and we've done this here every year over the last few years. I come here and talk about macular degeneration because it's a very common disease. And my specialty, I'm an ophthalmologist, but I'm a subspecialist in treating different retinal diseases, and macular degeneration happens to be one of the very common conditions that I see every day in my practice. And I think it's very relevant because over the last 10, 15 years, there are new treatments that are available. And the more patients know about this condition, the more they know about what signs and symptoms to look for, and the more aware they are, the more we can help. Because the sooner we can intervene, as you will see in my course of talk today, the better the outcomes. And this condition being so common, you'll be surprised how many people still don't know about macular degeneration. So I'm delighted to be here. We're going to start. I wanted to start by just sharing some facts about macular degeneration. Number one is macular degeneration. You may not know, but it's the leading cause of blindness in the developed countries. Now, when you look globally, and when you include some of the countries that don't have access to health care, cataract happens to be the leading cause of blindness, which is a shame because cataract is a reversible cause. You get cataract, you fix it, your vision is restored. But in the U.S., because cataract is usually taken care of timely in most patients, it's the macular degeneration that's the leading cause of blindness. And just to put things in perspective as far as how many people are affected, about 11 million people in the U.S. are affected by macular degeneration. And that number, and most people know about cancer, everyone is scared of cancer, and it gets a lot of attention, and it should, because a lot of people unfortunately lose their lives to cancer. But equal number of people are affected by macular degeneration, and the degree of awareness about macular degeneration is definitely not to the same degree as it is with cancer. So it is as prevalent and also as important as cancer is, and you'll be surprised how many people don't know about it. So macular degeneration is a degenerative disease. It's something that becomes more prevalent as we age. So it's considered one of the degenerative diseases of the retina that is progressive, meaning that as you age, the disease progresses, and as the disease progresses, vision gets more and more affected. Now, macular degeneration is becoming a very important condition. Partly is because we're living longer. I mean, it's not only macular degeneration. I mean, you look at cardiovascular diseases, you look at degenerative arthritis. Many of these diseases are now are playing a bigger role because we're dealing with people living longer. So if you look at this graph over the last 50 years, the life expectancy in the United States has gone up by about 10 years. So that's why a lot of these degenerative diseases are becoming more and more prevalent. Here's the slide that's just, it's showing that how the population of aging is increasing in the U.S. And over the next 15, 20 years, the number of people affected by these degenerative diseases are going to be more and more. And that's why it's important to have proper understanding and proper treatment options for these patients. To sort of set the stage, I wanted to show this video. It's an animation about how the eye works. So the eye is really works like a camera. So vision actually doesn't occur in the eye. It happens in the brain, as you may know. And the eye is a tool. It's an instrument that's responsible for transmitting light energy to electrical signals and send it to the brain. So, the outer portion of the eye is an optical system. It has the cornea on the lens, And then back of the eye is where the light-sensing tissue is. And that light-sensing tissue is called retina. And retina works very similar to how the film works in a camera. So once an image is projected on the retina, what retina does, it transmits that information, it captures that information, and it sends it to the brain by the optic nerve. And the sensation of vision happens in the brain. So as you can see in this animation, light is projected, it's focused by the optical system in the eye, the lens, and then once the image is focused on the retina, that information is converted to electric signal, and that information is sent to the brain from there. So how does macular degeneration affect vision? There's a few different things that happens once macular degeneration progresses. Now, at the initial stages of macular degeneration, patients are not affected. They may not even know they have macular degeneration until things progress, until more degeneration happens. And usually, common symptoms are central vision loss. So, for example, reading becomes a lot more difficult, recognizing faces becomes more difficult. But peripheral vision usually remains. So macular degeneration usually does not cause total blindness, but it affects central vision. That can create significant disability, but it usually doesn't make patients sit in the dark. So the light sensation still is there, but the clarity and definition of vision goes. Other things that can happen, you may have distortion if there's a lot of leakage under the retina. Color and contrast can also get affected. But in patients, the biggest complaint that I find patients have is a difficulty with reading. That's usually one of the things that significantly is affected with patients with macular disease. Because, you know, for a person to be able to read, you really got to have a good macula. And once areas of the macula are degenerated, following the letters becomes very difficult. And that's one of the things that I find in a lot of patients that they miss is ability to read. Now, common things there are two different kinds of macular degeneration. You might have heard about dry and wet macular degeneration. And but most people that get macular degeneration, they usually have the dry kind. The dry kind tends to be slower in progression than the wet macular degeneration, but it still can cause significant vision loss. Wet macular degeneration is usually seen about 15 to 20% of patients, and usually patients start off with the dry macular degeneration in this picture, and they may convert, and they may develop a wet type of macular degeneration. The reason it's called wet is because there's usually bleeding, or sometimes leakage, exudation in the macula, and that's why we use terminology wet. And being able to diagnose the difference between these two types of macular degeneration is very important because the treatment options are different. So, one of the things, now how do we diagnose patients with macular degeneration is number one, you got to examine the patient. So we do get referrals all the time with patients with macular degeneration. The first thing we need to find out is what kind of macular degeneration it is. And we do different diagnostic testings. You may already be familiar with the picture at the bottom of this. This is a technology called OCT, where you can, based on the reflection of laser from the macula, you can really see very magnified view and exactly see at cellular level what's happening. For example, this picture, it's a patient of mine who has wet macular degeneration. You can see there's areas of fluid under the retina. So that's one of the important tools that we have to diagnose patients with macular degeneration. And you may sometimes have seen me in the clinic here, and I usually recommend for you to come to my office in Los Alamitos because we do need these capabilities, which sometimes we don't have at Leisure World. We also do angiography. It's a test where a patient is given a dye in the arm, usually in the vein, and we take some pictures from inside of the eye. We're basically looking for abnormal blood vessels under the macula. And that's the hallmark of wet macular degeneration. So that's how we distinguish between dry versus wet macular. One of the reasons that I mentioned that it's very important to be able to diagnose the difference between dry or wet macular degeneration is treatment. Wet macular degeneration, if it's not diagnosed on time and treated on time, it can lead to a permanent and significant central vision loss. And there are treatments that we have, and with those treatments, we can protect vision in a lot of patients as long as we're able to get to those patients timely. And the reason for that is because if there is bleeding and leakage under the retina, and that problem is not diagnosed timely, scar tissues can develop. And once the scar tissues are developed in the macula, unfortunately there's not much that we can offer. So here's a picture of patients that has a lot of bleeding under the retina, as you can see in this picture, and if that patient is not treated timely, it will turn into scar tissue. And that scar tissue, unfortunately, once it's seen, there's not a whole lot we can do. So, being able to properly diagnose a patient, having access to the technology that's needed, being able to scan the macula is very important in managing patients with macular degeneration. So I'm going to talk about what we do for patients with macular degeneration. Usually, every time I see a patient with macular degeneration, these are my goals. Number one, find out who's at risk for vision loss. And there are some patients that have higher risk of vision loss from macular degeneration, and those are the patients that we need to follow up with more frequently. So number one is finding out who is at risk of vision loss from macular degeneration. And there are ways that we have. Not every macular degeneration carries the same degree of risk. There are some types of macular degeneration that carry lower risk, and those patients don't need to necessarily be followed up every 1 or 2 months. Those patients are seen usually yearly. So being able to distinguish and diagnose properly and find out who's at risk is important. And once we diagnose who's at risk, we try to minimize those risks. There are things we can do as far as lifestyle changes and some dietary supplements that can help reduce risk of vision loss from macular degeneration. And once a patient is diagnosed with wet type of macular degeneration, we want to start treatment as early as possible to minimize risk of vision loss and reverse some of the vision loss that's occurred. A lot of patients might be surprised that once a patient is diagnosed and once the treatment is started, sometimes we can improve vision, and with treatment we can make a significant impact. And unfortunately, there are some cases where patients have developed scar tissue or significant degeneration where we get to a point where we can't really offer any treatment to improve their vision. And those are the patients that we want to, as much as possible, improve their quality of life by referring them to proper centers so they can have access to visual aids to maximize their vision with their degeneration so they can have the best quality of life they can have. So let's talk about dry macular degeneration. As I mentioned, more patients with macular degeneration have the dry type, about 80%. But fortunately, dry macular degeneration does not progress as fast. And the reason I say fortunately is because there's no treatment at this point for the dry type of macular degeneration. We are involved in some clinical trials. There are some new drugs in development for dry macular degeneration. We're hoping that within the next couple of years we may have something in clinical practice to help those patients. But as of today, dry macular degeneration has no treatment. Now you may ask me, oh, what about the vitamins that you've been recommended by your eye doctors? Those are mostly to reduce the risk of vision loss, to slow down the progression. But once the degeneration has occurred, there's nothing we can do to bring the eyesight back because we're not there to be able to regenerate the retina. We're hoping that in the near future we can. There's a lot of work that's being done with stem cell, but they're still in the early phases. So it's very important for a patient who has dry macular degeneration to prevent vision loss and to minimize the risks. And the biggest risk that we can modify is smoking. Smoking can increase risk of vision loss in someone with macular degeneration by 3-folds. So the best thing that someone can do with macular degeneration who smokes is to quit smoking. But fortunately nowadays, I see less and less people smoking. But the risk factors, there's some of these we can't really do much about: age, race, family history, genetic makeup, those we can't do much about. But smoking is one of the main reversible risk factor. I'm going to talk to you guys about vitamins for macular degeneration, because in my previous talks is always one of those areas that people are interested to know about. So the story with the vitamin and macular degeneration came from a large clinical trial called AREDS. You might have heard AREDS formula or AREDS vitamin. They had two questions. The question was, if you supply patients who are aging with high doses of different vitamins and minerals, can you reduce risk of cataract? That was one question. And then the second question was, can that reduce risk of vision loss in patients with macular degeneration? So the answer to the first question was no. That had no effect on cataracts. There's no vitamin that can help patients, can prevent patients from getting cataract. But the answer to the second question was yes. If you have already macular degeneration at an intermediate stage, and if you start using these vitamins, you can reduce risk of vision loss. It doesn't stop it. It reduces the risk by about 25% over 5 years. So that was the result of the ARED study that came out in 2005. And it became standard of care for us to recommend vitamins to patients with macular degeneration. And these were components of the ARED study. It was vitamin C, vitamin E, beta-carotene or vitamin A, zinc and copper. Now this study was modified because they continued to look at these patients, and a new study came out in 2013 called AREDS 2. That was a continuation of that original study. And the study, they tweaked around the formula, so they added lutein and zeaxanthin. There were two components that were missing from the original AREDS 1 formula. And those two components basically replaced vitamin A. And the reason they did that is because vitamin A in someone who had a history of smoking increased risk of lung disease. So they wanted to make do without having vitamin A in the formula. So the new recommendation is AREDS 2, which does not have vitamin A, but instead of vitamin A, it has lutein and zeaxanthin. So some of the modifiable risk factors, I just want to emphasize this about smoking. There are many studies that show sedentary lifestyle and obesity also increase risk of progression for macular degeneration. And some of the good habits to have: exercising, keeping active, dark leafy vegetables and nuts are not bad to have in the diet. So just to backtrack, dry macular degeneration, just to summarize, has no treatment. What we can do is to modify risk factors. If you have intermediate level of dry macular degeneration, we recommend vitamins. And then we monitor these patients, because there is a 15 to 20% risk that someone who has dry macular degeneration can convert to the wet type. And we don't know who is going to convert when. So we typically ask patients to check their vision. If they have any distortion, decline in central visual acuity, report to us. There are some grids that we give them to have it at home, and we ask them to check their vision with the grids. And the reason we do that is because we want to be able to catch someone who's converting from dry macular degeneration early on and put them on treatment, because wet macular degeneration has been a success story for us over the last 10, 15 years. So wet macular degeneration is just sort of how things panned out over the last 30, 35 years. So if you were someone who developed wet macular degeneration before 2005, you were out of luck, because there was not a whole lot of good options we had. We would use laser to treat patients with macular degeneration, and laser itself caused significant vision loss. And frankly, it was unheard of for us to be able to reverse vision loss. If you develop wet macular degeneration, usually in about 6 months, patients progress to legal blindness. Now in 2005, that story completely changed, and one of the reasons it changed is because we understood the mechanism of macular degeneration at a molecular level. Now we know exactly what happens at a cellular and molecular level for these blood vessels to grow, and we have drugs that we can target those blood vessels And a lot of that credit goes to all the research that gets done on cancer. A medication that's being used to treat patients with cancer was found to help patients with wet macular degeneration. It's a drug that prevents growth of blood vessels. You know, as you might imagine, if a cancer wants to grow in the body, it needs a lot of blood. It needs nutrient and oxygen because it wants to outgrow the rest of the cells in the body. So what cancer cells do, they're very smart. They recruit and they grow their own blood vessels. And what we realized was that these cells produce a signal, produce a protein that acts like a signal that turns on the growth of these blood vessels. And we came up with a drug that blocks that signal, and that really changed, revolutionized how we're treating patients with macular degeneration. So in 2005, a medication called Avastin became available for intraocular use. A year after that, another medication became available by Genentech called Lucentis, and in 2011, a third drug became available called Eylea. And all of these drugs are very, very effective in managing patients with macular degeneration. And if you look at the results, about 90% of times we can prevent patients losing their eyesight, as long as we can catch them early. About 35% of times we can improve their vision, as long as it's caught early.
These are injections?
These are the intraocular injections, the eye injections, right. So the eye injections are one of the very commonly performed procedures in a retina practice. Yes?
Does it matter which ones you received of the three that you mentioned?
That's a very good question. The answer is yes. Everyone is different. So all these three drugs, people respond differently to different drugs. We typically start most people on Avastin because it's significantly cheaper than the other two drugs, Lucentis and Eylea. But if on follow-up exam we realize that Avastin is not working as well as it should, then we sometimes switch them to the other two drugs, and we try to see which one works better for what patient. But I could probably say about 80 to 85% of patients get Avastin. They do just fine with that. But sometimes we have to use the other drugs to find out who responds better. The problem is this. The problem with the intraocular injection is that they need to be repeated. They only last about a month in the eye. So one of the burdens for patients is that once they're diagnosed with having wet macular degeneration, it's a chronic disease. It's like a diabetic patient who needs insulin. It's not cured. These drugs are not cure for the condition, but they prevent vision loss. And as long as we give the shots, patients do well. But once we stop injecting, those blood vessels can grow right back and they can leak or bleed again. Now, the story is not the same in everyone. There are sometimes cases where we can stop injecting and monitor those patients carefully. But you always need to get monitored because you just don't know when they're going to grow back again. So typically, we start treating patients every month with these shots. And then we slowly extend the interval between the injections. So we go from 4 weeks to 5 weeks, 5 weeks. And then we'll see exactly how much we can push the interval between the injections. There's a lot of work that's being done, because that's one of the burdens right now is just the need for the frequent injections. So there are some drugs in the pipeline which are sustained release, and we're very excited once they become available. But at the moment, there's no sustained release system that we can make it without the need for these frequent injections. One of the things I wanted to mention to you guys about the cost, macular degeneration is very prevalent, and we're dealing with an aging population, so as time passes, we have more pool of patients that we have to take care of. The question is the cost. The cost of medication, and that's one of the reasons I told you we start everyone on Avastin, is the cost. The cost of Avastin is about $40 per injection. And the reason it's cheap is not because it's a bad drug. Most people say, oh, it's a cheap drug, must be bad. That's not the case at all. The reason Avastin is cheaper than Eylea or Lucentis is because is made in a large quantity for systemic use in cancer patients, and is aliquoted to many different doses that are used in ophthalmology practices. That's why it's cheaper. And they've done studies. One of the most important studies that was done was called CATS trial, and one of the questions it tried to answer was which drug is better between these three that we have available. And as far as the efficacy goes, they're all fairly similar in terms of the efficacy. Eylea sometimes can last longer in the eye, so sometimes we can extend the interval between the injections more. But a lot of it is what we try to do when we treat patients with macular degeneration. We try to tailor the treatment to patient and find out exactly what works best for that individual patient. And if you feel that Avastin is not doing the job and is not as effective as it should be, we switch them to the other two drugs that we have. As far as distance vision goes, you need a telescope. And the problem with the telescopes for distance viewing is that they come with a very narrow field of view. So you may be able to see something at distance, but it would be at a very limited field of view. And one of the things that became available a few years ago was this intraocular telescopes. I don't know if you guys have heard about it or not. But it's a device, it's a telescope that gets implanted in the eye, usually in patients who haven't had cataract surgery, because that's when they take the lens out and they implant this particular telescope in the eye. And this telescope magnifies the image that's projected on the retina. Let me show you this video clip. You may find it interesting. So, again, as I mentioned to you, they're trying to work on making this available for patients who have had cataract surgery, but at the moment, it's only available for patients who have their own natural lens. So here is just a simulation. So when you have dry macular degeneration and you've lost your macula, whatever is projected on the area that's degenerated, you're not going to be able to see. And what the intraocular telescope does, it magnifies that image, so it basically projected outside the border of the retina that's already degenerated. That's basically the whole logic behind using intraocular telescopes, is that you magnify the image outside of the macula, outside of the area that's degenerated, so patients can see it. I'm going to skip to the next video. It's a surgical video that shows how this intraocular telescope is implanted. Again, this is first they're removing the cataracts here, the lens of the eye is being removed, and then the next thing they do after that's done, they make a little bit of a larger incision on the eye to get this telescope, and that's the telescope before it's implanted. And that telescope is implanted in the eye. So it's a little bit longer surgery than regular cataract surgery, but for someone who's lost vision, it could be very helpful because it can improve the quality of life. So it was my pleasure to be here. Again,